Hello and welcome to this lecture. Today we are going to discuss rheumatic valvular heart disease. So I am going to present the case of a 44-year-old man with a history of rheumatic outbreak in childhood and adolescence and multiple aortic valve replacement operation was admitted with decompensated heart failure. The current disease started with a rheumatic outbreak that were characterized by fever and arthritis, which is the inflammation of the joints of the right knee between 7 and 11 years old. And at 15 years of age, paroxysmal palpitations, which is known as sudden arrhythmias, appeared. At the age of 16, he started outpatient follow-ups. A diagnosis of double aortic lesions, which is a congenital cardiovascular malfunction, is identified, and active rheumatic disease was made. The electrocardiogram at the time revealed severe left ventricle overload. Chest radiography revealed cardiomegaly. At 17 years of age, palpitations become more frequent and dyspnea appeared on medium exertion. So that's a case study. And let's discuss the objectives that we need to define the rheumatic valvular heart disease, understand the epidemiology of that disease, discuss the pathogenesis of rheumatic valvular heart disease and morphological and clinical features of the disease. When we discuss the rheumatic valvular disease, is a disease in the cardiac manifestation with the rheumatic fever, and it is in acute, it is immunological mediated fever because of the multi-system inflammatory disease, could be caused because of the inflammatory autoimmune disorders or idiopathic autoimmune disease. And we discussed that is the inflammation all part of the heart, that is the main thing that result in valvular inflammation and scarring. And with the inflammation and scarring, it can lead to deforming mitral stenosis, especially fibrotic mitral stenosis. So what happened, this is a normal mitral valve, and what happened that the narrowing of the mitral valve, which is known as mitral valve stenosis, occur. So you can see that the valve, normal valve, have big opening, big diameter, whereas when compared with the narrowing of the mitral valve, they become very small, having small diameter. And then what happened then, when under normal circumstances, the blood can go into the left ventricle. And what happened in mitral stenosis, the mitral valve, because of the narrowing of them, blood faces difficulty, or you can say obstruction, to go into the ventricles. It declined remarkably in the Western world from the past several decades because of the improved socioeconomic conditions and because of the rapid diagnosis and treatment of streptococcal pharyngitis if the arthritis is caused because of the streptococci, which is the bacteria. So what will be the pathogenesis of acute rheumatic fever? There will be the hypersensitivity reaction because of the antibodies production against a streptococci molecule, which is a bacteria that react with the host antigen. And in particular antibodies against M protein of certain streptococcal strain bind to protein in the myocardium and cardiac valve and cause the activation of the complement system and receptor bearing cells, including macrophage. So what they are doing, actually, that the streptococci, which is a bacteria that are responsible for inflammation, they are responsible for binding with the myocardium, which is a muscles of the heart, and then the cardiac valve. And then by binding of the streptococcal, especially the M protein with the myocardium, it can cause injury. And how they cause injury? By activation of the complement system and the other FC receptor bearing cells, which consist of macrophages. And then it is also responsible for in terms of the adaptive immunity, like CD4 T helper cells, that recognize these peptides and then cross-react with the host antigen and exhibit cytokinin mediated inflammatory response. And we know that there are two types of response, innate immunity and adaptive immunity. And the T helper cells will be produced under the cytokinin mediated inflammatory response. And these T cells or CD4 cells identify the streptococcal peptides and then cross-react with the host antigen. Since only a small minority of the infected patients develop rheumatic fever, genetic susceptibility is likely to influence the development of cross-reactive immune response as well, because some people have cross-reactive immune response because of the idiopathic reason or autoimmune disorders, which is linked to the genetic factors. So the genetic susceptibility can also likely to affect if a person having infected with streptococci or streptococcal related inflammation, and can become more worse if with the genetic biomarkers. So what will be the effect, what it will do? Again, this is actually, you can see that the valvular tissues, these are mononuclear cells, the round structures, and these are cross-reactive antibodies that bind with them. And actually I mentioned here that the streptococcal or self-antigen cross-reactive antibodies facilitate heart tissues T-cell infiltration. So the formation of the cross-reactive antibodies on the heart muscles, especially or in the valvular tissues or in the myocardium, they are responsible to facilitate the T cells to bind. So if these CD4 T cells actually binding with the cross-reactive antibodies, and then they can affect the valvular tissues. And I mentioned that CD4 T cells recognize streptococcal antigen and heart tissue protein, and then they are responsible for the production of inflammatory cytokines such as tissue necrotic factors are IFN gamma, which is interferon gamma, which is produced by mononuclear cells. And then for a few mononuclear cells produce intraleukotriene 4, which is regulatory cytokinin leading to progressiveness and maintenance of the valvular lesion. So what happened that the surgical specimen of the acute rheumatitis showing you small vegetations like these projections, just like small finger-like projection on the line close to the mitral valve. So this projection will be clearly appear in around the valve or around the closure of the mitral valve. Let's discuss the morphological characteristics. Acute rheumatic fever is characterized by, again, discrete inflammatory foci with a wide variety of tissues, because it can affect the valves and can affect the myocardium. So the myocardial inflammatory lesions can be explained in terms of A-skiff bodies. And during acute rheumatic fevers, skiff bodies can be found in any of the three layers of the heart, which is the pericardium, myocardium, or endocardium, including the valves as well. So the main key characteristics in rheumatitis, acute rheumatic fever, or especially the rheumatitis or rheumatic valvular disease, is A-skiff bodies. And this is a picture of this arrow picture, this showing you the presence of the A-skiff bodies, which consist of fibrinoid necrosis and their combination of the immune cells. As we know that the CD4 cells are responsible to bind with the antibodies, and then they make the A-skiff bodies. Again, this is the finger-like, you can say the small finger projections around the valve. And I mentioned that acute rheumatic mitral valvulitis on chronic rheumatic heart disease, small vegetations, these all are known as vegetations along the line of the closure of the mitral valve. And the previous episode of rheumatic valvulitis caused fibrosis, thickening, and fusion of cordia tendini. What is cordia tendini? This is actually the threads. These threads are known as cordia tendini, and they are present around the mitral valves. So chronic rheumatic heart disease is characterized by acute inflammation, subsequent scarring, formation of ascuff bodies, which are replaced by fibrosis scar later on. Then it is responsible for the valve cups and leaflets to become thick or retracted. It means it can become shrink, and either it can become permanently enlarged or thick. And the mitral valve exhibit thickening, leaflet, commissural fusion and shortening, thickening and fusion of cordia tendini, and valvular stenosis and regurgitation. So what happened in regurgitation in mitral valve stenosis? It is just like that. It's restricting the blood flow into the main pumping chamber. And what happened that your mitral valve may also leak, causing the blood flow to flow back through the valve each time to the left ventricle contract. So it how can be explained? It can be explained in terms of the reflux back. So we mentioned that mitral valve exhibit thickening and commissural fusion. How can we express commissural fusion? It can be expressed that these are cordia tendini, and then they fuse together. And because of their fusion, they can causing commissural cordi. And you can see, take a look of them because of their commissural fusion, the shape of the valve will become altered, will disturb. So we mentioned here that commissural fusion is occur around the corners of that valve, and then there will be marked left arterial dilation. We will find fibrosis or distortion of the valve leaflets. So you can see this structure that around on the surface, this is known as leaflet, and we can find the thickness around the leaflet, and so you can see this V-like structure. Again, I'm going to show you. Okay, let's clear this. This V-like structure or U-like structure is actually the leaflet, and you can see that the commissural fusion occur around the corners, as mentioned in the black arrows, and then the thickness around the leaflet will be observed, and then shortening of the cordia tendini. That these all combination of things that will change the gross structure of the valve. And the clinical features will be carditis, the migratory polyarthritis of large joints, and then subcutaneous nodules, erythema marginatum, skin rashes, and then we have sydenum chorea. This is a picture of subcutaneous nodule that will be produced during that disease. When we discuss erythema marginatum, it means the formation of round rash-like structures. You can see the round, you can say the marginatum. So they're making the rash is red-like structure. Then the other clinical indications are sydenum chorea, which is irregular, abrupt movement of the body. So thank you so much for today's lecture. Hope to see you again.